Pregnancy is normal. I think it's really important that we realize I am not standing up here talking about a disease state. Pregnancy is a normal state. Women were meant to be pregnant, and it's a very normal physiologic occurrence. I also want to emphasize that you don't have to be perfect, and none of us are, in the conduct of a pregnancy, and thank God most pregnancies work out very well, even without us being perfect. And I think that's important because I think in today's day and age there's a lot of guilt associated with pregnancy, and I don't think we need to be quite as guilty as a lot of us feel. I think the take-home message from this talk is that preconceptional visits really help. That it's important, if you have a problem, to come to see us before you get pregnant so you can be in the best possible shape when the pregnancy begins. So, what's the definition of high-risk pregnancy? And the answer is, I don't know. When you go on the website and you look on the internet and you look for the definition of high-risk pregnancy, you're going to have 15 different explanations of what a high-risk pregnancy is. And so it's really, to a large degree, in the eye of the beholder. But I think if you stratify it, if you separate it out into these three categories, you'll cover most high-risk pregnancies. And that is, there are maternal indications, problems with the mother, problems with the fetus, and problems with the pregnancy itself. The facts are concerning. The incidence of premature delivery in this country is about 12%, and 8% of all babies are a low birth weight, which is defined as under 5 pounds. 11% of women still smoke in pregnancy, and 10% drink during pregnancy. And remarkably, and we'll talk about this in greater detail, about 2/3 of women still don't take folic acid supplements. About 1/3 of women today are obese when they conceive their pregnancy, and a fair number have pre-existing medical conditions, and even those without, about 1/3 of pregnancies end up with complications before the delivery. We've done dramatically better over the last 40 years in reducing the incidence of maternal death and infant mortality. As you can see, the graph starts in 1960 and goes down to 2002. And fortunately, we're doing much, much better in terms of losing both mothers and babies. The top two reasons for babies dying in this country are birth defects and prematurity. It's important that you realize that both of these issues, congenital malformations and preterm delivery, may be reduced by the mother seeing an obstetrician or a perinatologist prior to conception and starting the pregnancy, particularly if she's at high risk to begin with, such as a diabetic or a woman with hypertension or so on. Despite the improvement in infant mortality and maternal mortality, the incidence of low birth weight and prematurity is essentially the same as it was for the past 25 years. And what does this mean? It means that we're still not doing as good a job as we would like to in terms of reducing the incidence of prematurity. Despite all the medications and hospitalizations and surgical procedures, we still have an unacceptably high incidence of preterm delivery. The majority of women in this country get some prenatal care, but about 12-13% only start in the second trimester, and there's still almost 4% of women in this country that get very late or no prenatal care. And this significantly impacts on the outcome in the pregnancy. This is a long list of complications that the mother can have, which will influence both her health and the health of the baby. The number two problems that we see in high-risk pregnancies are diabetes and high blood pressure, although the list is really endless. Any kind of maternal disease can have an impact on the pregnancy. I would add, particularly in a family that wants to have a lot of children, that a previous cesarean delivery I would list as a high-risk condition. I'm going to stop for just a couple of seconds now. If anybody has any questions that they want to ask me, please feel free to jump in. We can make this a dialogue if you like. Okay. So as I mentioned, it's very important to have a preconceptional care as part of the multidisciplinary team approach. What this means is that we have internists and cardiologists and endocrinologists, whatever the medical problem is, participate in the counseling of the patient. And what this can help us do primarily is get the mother in the optimal shape prior to beginning the pregnancy, because really an ounce of prevention is worth a pound of cure in this regard. I just want to take 1 second to thank Rabbi Schnitzler, Rabbi Stein, and Rabbi Jacobowitz, who I think has an honorary medical degree, for really being so gracious and inviting me to give this talk. So thank you very much. So what happens if you have these medical problems? Well, aside from the effects on the mother, all of these medical conditions can result in a very low birth weight baby. And low birth weight babies are fraught with a lot of complications in terms of development and nutrition and further development, and sometimes mental retardation and cerebral palsy and so on, which makes it really, really critical to get these moms in the best shape possible prior to pregnancy. I want to just mention one thing here. You see on the slide thrombophilias. Thrombophilias is an interesting condition over here. Thrombus, it's from, I believe it's Latin. Thrombus is clot, and philia means love. It means the blood loves to clot. And in some conditions, the mother's blood loves to clot and results in clotting in the placenta, and it affects blood flow to the fetus and results, as you could see in the picture, of a very low birth weight baby. I want to use diabetes as an illustration. Women with diabetes have a much higher incidence of having babies with birth defects. Any chemical or drug that causes birth defects is called a teratogen. And glucose by itself, sugar, is a major teratogen. And if the diabetes is uncontrolled, about 40% of babies will have major birth defects. However, if you control the mother's sugar prior to the pregnancy, you can reduce the incidence of birth defects to that of the normal population. So, for example, I know, in this community, and I was talking to Rabbi Jacobowitz about this, and I know from my own patient population that you do a lot of genetic testing even prior to marriage. I think part of that, one should think of control of hypertension and control of diabetes to optimize the optimal outcome for your children to be. Mothers with diabetes can have a variety of medical complications such as cardiac disease and kidney disease, eye disease, and so on. And so it's important to get all the appropriate consultations prior to the mom becoming pregnant. In women with hypertension, you want to be in the best blood pressure shape possible prior to the pregnancy. Some medications are extremely dangerous in pregnancy. For example, there's a class of medications called an ACE inhibitor. It's very important, if the mom is on any medications prior to pregnancy, that she consult the obstetrician so she's sure that the medication that she's on is a safe one for the baby. There are certain conditions, as I mentioned. There's maternal and there's fetal and there's pregnancy high-risk situations. There's something called preeclampsia, which occurs in about 6 to 8% of women, in which they get high blood pressure and protein in the urine and swelling. It's always better for the mother to deliver the baby. It's not always better for the baby because it may occur in a very premature state. But one of the basic principles, which I think is also, and you can correct me if I'm wrong, I think it's also halakhically correct, that the mother comes first and the mother's health is paramount. And it really is very logical as well, because if the mother is not healthy, then clearly the fetus is not going to be healthy either. But the basic principle of maternal fetal medicine, which is why it's called maternal fetal medicine and not fetal maternal medicine, is that the mother's health always comes